Thank you, Corey. So I thought the best way to illustrate this would be through cases. So these are actual patient cases that I've seen in my practice or my partner's practice. And so we've got 4 cases to talk about. I am going to give you guys some questions, although I don't think we're using ARS for it, so we might just do a show of hands. And so we'll begin first with a patient. He was a 56-year-old Asian male, never smoker. You can see on the PET CT, very little disease, a small effusion here. And essentially, his labs were unremarkable, PS is 0, and he was getting a pre-op knee surgery. Chest X-ray showed a right lung abnormality. He had a mild cough, but he thought that was allergies. PET CT, however, did demonstrate that there was this right upper lung mass and right axillary lymph nodes and a small right effusion. The thoracentesis of the right lung came back as adenocarcinoma. So he shows up in your clinic. You do have PD-L1 IHC at 75%, and the molecular profiling is pending. And it's a 56-year-old Asian never smoker. So what do you do? So these are the current options, right? So PD-L1, 75%, you don't have molecular profiling back. Do you start Pembro, start Carbo-Pem-Pembro, Carbo-Pem, or do you wait 2 to 3 weeks for the molecular profiling, which can happen nowadays? Especially with the holidays, I would tack on an additional week. So I don't know, Corey, should we do a show of hands?
Sure, show of hands. Who would start Pembro? Who would start the triplet? Okay, 1, 2, you're going to have to count hands.
Okay, so there were spattering. No hands.
So who would wait?
Majority waits. Perfect. So very important because obviously Asian, male, young, never smoker. So odds are likely he's got an oncogenic driver and he's got pretty low burden disease. And the reason why it's advisable to wait in these patients is that there's a lot of data coming out now that the patients with the oncogenic drivers, specifically EGFR mutation or ALK, or the never smokers, they have a much lower response rates to immunotherapy. And so this was the data Gaynor et al. That demonstrated the low response rates in these patients. And this is held up in many of our subgroup analyses in the patients who are getting checkpoint inhibitors as monotherapy. So as everybody remembers, the CheckMate trials, which, I guess you're going to get the IO lectures tomorrow, but everybody's very familiar with the studies that were using salvage nivo. And across the board, when you look at the treatment effect on the EGFR mutated patients down here, you can see that they have less benefit with the immunotherapy as opposed to chemo. And this is holding up across the board in all of the monotherapy checkpoint inhibitor studies. So we generally believe that the ones who have oncogenic driver mutations don't have like a heavy tumor mutation burden because they're really driven by one primary dominant mutation. Now, that's not to say that they should never get an IO. It's just that we would never give IO in place of a targeted agent. Later on in their therapy, as they acquire additional mutations, maybe their tumor mutation burden gets higher, that would probably be the time to add IOs into their treatment. But we would never replace frontline IO for frontline EGFR TKI. And when we look at the Pacific phase 3 trial, I put this there mostly, you had the Pacific lecture earlier today. When we look at the subgroup analysis, well, the progression-free survival for this, to remind everybody, durva was superior to placebo. But when we look at the patients who had EGFR mutation, they did seem to get a benefit with durva, but it did cross the line. So the question is, earlier on in their disease, should we also think about IO? And I think the answer to that is we're not sure. But if these immunotherapies work better in patients who have a higher mutation burden, then they probably aren't going to get the same benefit as those that do have high tumor mutation burden. So the jury's still a little bit out in earlier stage disease, but the trend is looking like maybe they don't gain benefit as much. Okay, so the outcome for this patient, so obviously he came back EGFR mutation, deletion exon 19. So he went ahead, and this was previously a couple years ago, he had actually gotten Erlotinib and did very well for about 2 years, and then he went on to Osimertinib because he developed T790 mutation, and he's still on it. Okay, so we're going to kind of change the case to a 56-year-old Asian male never smoker, but now this is his presenting scan. So this is a guy who comes in again, pre-op chest X-ray, He sees this on the PET CT. He's got diffuse pulmonary nodules. He's got liver mets, adrenal mets. His thoracentesis also shows from the right pleural effusion a big effusion at the time. A right lung thoracentesis shows adenocarcinoma. Normal exam, PS is 1. Again, same thing. PD-L1, 75%. No genetic molecular profiling. He's still an Asian male, never smoker, but his scans look like this. Who's going to do Pembro? 1. Who's going to do the triplet, carbo-pem-pembro? 1. Who's going to do carbo-pem? A couple more people. And then who's going to wait 2 to 3 weeks with those scans, but still PS1? He's looking okay. Okay. So more people are waiting, probably because I just told you EGFR mutants don't do well with immunotherapies. So this guy actually looked really good. He looked much better than his scans showed. And we were able to wait for the genetic profiling, and he came back L858 EGFR mutation. And so it did work out for him. But I would tell you, you usually need to bring these guys back because they can crash pretty quickly. Okay, so that was the first case. Second case, we're going to be looking at someone with a high disease burden, 100 pack-year smoking history, 90% PD-L1 positive. Okay, so this is one of my patients. He showed up with a massive amount of disease. You can see on the PET CT scan here. He showed up in my clinic tachycardic. He had elevated response rate, respiratory rate, and blood pressure. He looked like he was about to crash. And he was diaphoretic and shaky. He had pretty much no breath sounds on the left upper lung, and I'll be honest, on the right side, he didn't sound that great either. PS was 2. He had a 100 pack-year smoking history, and he basically had gone into the ER, pretty tachypnic, and they did a chest x-ray, which showed this mass. They then got him admitted at an outside facility. They did a PET CT, which showed this huge mass, bone, liver, lymph node mets, and they were able to do a biopsy in-house, which came back as adenocarcinoma. But because when he was in-house, they told him that the tumor was too big to radiate, and they thought that he should get some chemo, he checked out AMA and showed up in our ER where I saw him. Well, actually, the ER actually sent him up to my clinic to be seen. So his path, when I got it, was adenocarcinoma. They had done PD-L1, which was 90%, but his molecular profiling was pending. Okay, so who would start pembrolizumab? Okay, maybe a handful of people. Who would do carbo-pem-pembro? More hands, okay. Who starts carbo-pem? No one. And who would wait 2 to 3 weeks for molecular profiling? No one. Okay, so kind of divided between pembro and carbo-pem-pembro. Okay, very quickly, Keynote 024, which you guys are going to get a lecture on tomorrow, I assume. This was a study that was looking at frontline patients with no oncogenic driver mutation, and they gave them pembro versus a platinum doublet. And so when we look at the overall survival data, very impressive. Pembrolizumab had a hazard ratio of 0.63. The median overall survival was 30 months compared to chemo at 14.2. And so that's just, something to keep in mind for this guy. Now, what he came back as was a KRAS mutation when we finally got it back. So I admit he was in really bad shape, so I admitted him, and I had radiation see him, but the field was too big to initially radiate, but they were able to do some palliative radiation to a small area on his back, and while that was going on, I gave him pembro. I would have thought about doing the triplet regimen because remember, they had an 80% response rate in the high PD-L1 expressors in the phase 2 study for 21G. But this guy was not in good shape. And because he was still pretty diaphoretic and shaky and he looked like he hadn't eaten in several weeks, I had to only give him pembro. But that's not to say that was the best or the right choice. I think if he would have been in a little bit better performance status, I would have attempted the triplet to try to debulk him more quickly. Now, luckily, the pembrolizumab did work, although usually with the checkpoint inhibitors, you have to anticipate for some of these patients it takes longer for a monotherapy checkpoint inhibitor to kick in. But luckily, he was able to get out of the hospital, and I'm giving him 2 cycles of the pembro, and he'll be coming back for imaging. We've already gotten imaging, he's responding, but I may do a triplet on him if his disease burden is still very high. Okay. So moving on now to case 3. And I guess, do we want to take questions, Corey, about these cases? Keep going, okay. So case 3. So this is a patient who is a 60-year-old Caucasian female, 20-pack year current smoker. And here's her scan. So you can see she's got a pretty large chest wall, 2 tumors here, and she's got something here in her left lung. PET CT didn't really demonstrate very significant disease. She does have a large groin mass, though, which is actually why she showed up. It's normal labs, normal vitals. She was going to her PCP for a routine checkup, and they found this left groin mass. The imaging, again, showed the multiple masses, and the biopsy of the left upper lobe of the lung showed non-small cell carcinoma. The patient's pretty asymptomatic. So she shows up to oncology clinic. Her path is adenocarcinoma, but everything is pending. So we don't have PD-L1, we don't have any molecular profiling. So how many would start pembro? How many would start carbo-pembro? Oh, I should put the caveat. We have no tissue left to do anything. We'll have to rebiopsy her to get anything, any molecular testing, which is going to be another 2 to 3 weeks, 3 to 4 given the holidays. And PD-L1 is probably going to take just a couple of days, but we have to rebiopsy her, so that's going to take another week, week and a half to get set up in order to get that done. How many would go to chemo, carbo-pem? Okay, so a few people would. And then how many would actually wait? And in her case, it's not going to be 2 to 3 weeks. It's probably going to be more like 4 to 5 weeks to get molecular profiling results. Ooh, so we have 3 people who would wait. Okay, so on her, she basically came back PD-L1 negative, and then she had no actionable mutation. She had an ATM and a Notch2 mutation. So the reason why people would be comfortable waiting is she doesn't seem to have, she's asymptomatic, she doesn't have a big disease burden. Most of her disease is external. It's not causing any organ damage. She doesn't have anything life-threatening. And she's a 20-pack year smoker. So maybe she had an ALK, maybe she would have something driving her mutation, BRAF mutation or RET, maybe ROS1. And so it's very reasonable in her case to wait. And so honestly, I waited. I did radiate her groin mass just because it was, very, it just was chafing on her and it was kind of growing pretty quickly. And we radiated this large chest wall mass, which actually looked to be almost about to break through her skin. So we radiated her while we were waiting for testing. And so afterwards, I gave her carbo-pembro, given that she was PD-L1 negative. And so you'll get data again from 21G showing the response rates for the PD-L1 negative patients for carbo-pembro. So 21G, again, I know that your lecture is tomorrow, but it was enrolling no one who had an oncogenic driver mutation, and they were looking at carbo-pembro versus carbo-pem alone, and then you did have a crossover on the study if you progressed on the chemo arm. The response rates with the carbo-pembro were 56.7% versus chemo alone at 32%, and 50% had ongoing responses. When we look at the progression-free survival, it did favor the patients who got the triplet versus those who got chemo alone. The median PFS was 19 months versus 8.9 months. And when we look at overall survival, you get a hazard ratio of about 0.59 and a p-value that's statistically significant. They didn't even reach the median survival for the triplet versus 21 months with chemo alone. So you will see a lot of us, even though this is a randomized phase 2, giving the triplet regimen because they did get FDA breakthrough designation, so you can get it covered now. So it is my go-to regimen now for patients, regardless of PD-L1 expression. meaning those less than 50% or negative. That's usually my go-to regimen right now. And I do give the pembro as maintenance afterwards. Now, in the patients who have PD-L1 over 50%, pembro itself is very appropriate to give. But like I mentioned in our second case, people who have massive disease burden that you have to shrink quickly, it is a consideration if their performance status is up to it to consider the triplet regimen. Okay, so last case. So this was a 60-year-old Caucasian male, came in, 15-pack-year smoking history, very bad disease, had high elevation over 4 times the upper limit of normal. He was also going into renal failure. He was tachy. He was pretty tachypnic in the clinic. I would rate it as mild respiratory distress, but he couldn't speak in full sentences. Markedly diminished breath sounds, especially in the right lower lobe of the lung. He had remarked on a clinical history of 2 months of progressive shortness of breath. He had gone to the ER. The chest x-ray showed bad bilateral pulmonary mets. He actually had seen an outside oncologist who had ordered a PET CT, which showed diffuse pulmonary nodules, lymphangitic spread of disease in the lung, multiple liver mets, there were adrenal mets, lots of bone mets everywhere. And the brain MRI also showed multiple subcenter metastases, about 2 to 4 millimeters, just diffusely throughout the brain. So what I got was a pathology of adenocarcinoma. PD-L1 was 80%, but the molecular profiling was pending, and this guy looked like crap. So what would you do? Who would do pembro? Okay, and who would do carbo-pembro? Okay, a couple more. And who would start carbo-pem alone? Okay, and how many would wait? Okay, nobody's waiting.
What if you didn't answer, which means the patient's going to die?
Okay, so this came back. Fortunately, by the time I had seen him, within 2 days, so I had the benefit of this. His doc outside had actually sent off the genetic profiling. Within 2 days, luckily, after I admitted him, and I was getting ready to actually give him platinum PEM. At the time, pembro had not been approved yet, but he came back as EGFR mutation deletion exon 19. Now, at the time that I had seen this patient, Osimertinib was not available, but he did have brain mets that were diffuse. We actually had him seen by rad-onc, and they started off with whole brain, and we actually also gave Erlotinib. But again, that has now all changed. As we mentioned before, I would not, if I had this patient today, I would not start him off with an immunotherapy, but that's just me, because the odds, just based off of his radiographic appearance, were suggestive that he would be a mutant. And I just want to remind everybody, they're getting an EGFR lecture later, right? We didn't have it yet. Tomorrow, okay. So you're going to hear about the FLAURA trial. So this is a study that is a frontline trial in patients who had EGFR sensitizing mutations and no prior EGFR TKI therapy, and they gave them Osimertinib versus standard of care Erlotinib or Gefitinib, dealer's choice. And then they looked to see how the patients did. And the bottom line from FLAURA was that there was a markedly superior progression-free survival with a hazard ratio of 0.46 and a p-value highly statistically significant. And also when you looked at CNS metastases, because the unique thing about Osimertinib is not only is it good quality of life and toxicity profile looks good, but it crosses the blood-brain barrier and it provides protection in the brain. And so when you look at the patients who had CNS metastases at baseline, you can see that their hazard ratio was superior with Osimertinib versus your first-gen EGFR TKIs, hazard ratio 0.47, p-value highly statistically significant. And when you look at the objective response rate and duration of response, again, it did favor Osimertinib for median duration of response. In terms of response rate, it's pretty equivalent to the first-gen EGFR TKIs, but PFS duration of response is longer. And then perhaps more importantly is the overall survival, where we do see that the Osimertinib, the median OS hasn't been reached yet, but it appears the hazard ratio favors statistically significantly Osimertinib for overall survival. So particularly in your patients that have these diffuse brain mets all over that previously we had to give radiation whole brain to, you don't have to do that now. You can give Osimertinib frontline to these patients and potentially see complete control of their disease. So I have had a similar patient that came to me almost identical to this guy that I gave Osimertinib to, and within 3 weeks, his disease is completely cleared in the brain, and we didn't have to give him whole brain radiation. Okay, so to answer Corey's question, again, I don't have literature to provide for you guys because there's a great paucity right now. It's mostly all retrospective analyses. But in summary, our genetic mutation panels, blood and tumor, should take about 2 to 4 weeks to return, depending on where you are and what system you're using. IHC testing can take anywhere between 3 to 7 days across the country. And this is not even including if you have to biopsy the patient or rebiopsy. So your decisions on when to wait and when to intervene are really dependent on your index of suspicion that the patient has an oncogenic driver mutation. Also, what is their disease status? Are they in a life-threatening situation? And if that's the case, you need to act. And you really can't wait for the mutation profiling to return. It's okay in those cases where the patient has a life-threatening disease to give systemic chemotherapy for a dose while we're waiting for the genetic mutation to return. The line of therapy also matters. So if we're talking frontline, you better get that treatment into them if they have a life-threatening disease. In the salvage setting, if they have progressive disease and it's rapidly progressing, you should intervene while you're looking for their genetic testing. But our hope is that everybody gets tested up front, so you should have an idea of what their genetic driver might be. The pace of their disease growth is very important, so that's how you have to make your treatment decisions. Also, the patient's performance status. That makes the difference in the setting of frontline where you're going to do carbo-pembro versus pembro alone for someone with high PD-L1 expression. So if their disease is, if they look okay, and their disease is not that huge, you can do pembro alone. But if you've got somebody who's physically fit, who has a huge disease burden, you might want to think about the triplet with pembro, even in those cases where they have high PD-L1, if you really need rapid debulking of their disease. And then lastly is patient comfort level. So some patients now, because of the commercials, they think IOs are the be-all, end-all, and they think they don't need chemo. So that's a conversation between you and the patient and you getting them more comfortable with that thought. And so those are my tips about how you make a decision, when to intervene, when to wait.